essentially we found a specific pathology because of a large ovarian cyst which was responsible. And what we'll do in this perspective is try to discuss about various scenarios in which different forms of this peripheral precocious puberty presents. How is it different? What sort of evaluation is required, and how do we manage about this? This was a 3-year-old girl who presented with vaginal bleeding. She had thelarchy within 2 weeks, stage 2 breast development and pubic hair, and she was not very tall in that regard. So this is a very, very unusual scenario. Normally we talk about how there is a gap of approximately 1 year between the onset of thelarchy to the progression as far as the vaginal bleeding is concerned. Now, in this scenario, what we are seeing is that there is just some breast development which has happened in the last 2 weeks. And since then, you have a vaginal bleeding, which suggests that this is an extremely hyperestrogenic state. So estrogen becomes too high, the breasts don't get time to progress, and you have got vaginal bleeding. Now, vaginal bleeding typically happens when there is a withdrawal. So usually it means that the cyst now is not forming a very high level of estrogen. So your estrogen levels are coming down, and now the bleeding happens. So this is what was assumed in this case. There were no features of cafe au lait spots or rickets, and the parameters which showed that the LH and FSH was undetectable, and estrogen levels were reasonably high at that point of time. Now, what I'm trying to say is that this is the phase when your estrogen is weaning off. So probably this is the time when this 43 estrogen, which is very high for this girl, the levels would have been even higher, going up above 100 also in many scenarios of peripheral precocious puberty. So this was a classical case, and it was found to have an ovarian cyst which was detected. Now, the big question here is what to do from here. So most of us thought that, okay, there is no other clinical features of hypothyroidism, no features of McCune Albright syndrome. So let's reassure this girl and just follow up on that perspective. But what happened that she presented a couple of years later with a trivial fall resulting in fracture, which was attributed to a fibrous dysplasia, which was developed. Now, there are no other clinical manifestations of McCune Albright at that point of time, yet she actually behaved like McCune Albright in that perspective. So this really highlights that even if you have an isolated ovarian cyst, if it's happening at a very early age, you have to think of a genetic cause. And I always say if you have a severe, syndromic, soon, or segregating etiology, these are the 4 conditions where genetic causes have to be considered. And McCune Albright is essentially a somatic disorder. And when you talk about a somatic disorder, the manifestations will depend upon how many cells are affected. So you may or may not have the entire spectrum, which is there in that perspective. So what we'll try to do over the next hour or so is try to cover 4 of very interesting cases and how they differ and make appear similar also in various perspectives to go from there. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of resources regarding pediatric endocrinology, including courses, online courses for fellowship and diploma programs. We do run a number of monthly programs like our lecture series for postgraduates, for grand rounds, and these programs try to cover the entirety of pediatric endocrinology over a 2 to 3 year period from that regards. Our mobile application helps guide, evaluate, assess, and manage conditions along with our publications, both basic and advanced pediatric endocrinology. And just recently, last month, we brought out this pediatric endocrinology protocols, which covers the various aspects of evaluation and management. Now, what we're going to do over the next hour or so is try to cover 4 cases. So we have got an infant with ovarian cyst, which initially Dhwani will talk about. Then we have cyst with cystic lesions, skin lesions, young girl with ovarian cyst, and finally a girl with short stature and ovarian cyst. Before we do that, we will have a look with regards to a basic understanding of what we are talking about before we go ahead deep in terms of individual cases. So when we talk about puberty, we know that there are 3 major organs which regulate the pubertal onset: the hypothalamus, which produces the GnRH, the pituitary, which produces the gonadotrophins, and the ovary, which produces the estradiol. Now, within that, we typically classify this into a central form of precocious puberty, where you have got a high level of gonadotrophins. It's more of a concordant development. Typical gap between thelarchy and vaginal bleeding is around 1.5 to 2 years. If it's less than 1 year, we start thinking that it doesn't look like a central precocity, and then mostly it's idiopathic. While peripheral precocious puberty is more like a ovarian estrogen production, characterized by hypogonadotropic scenario, low LH-FSH, discordant pattern. Like in the first case, you had got a breast development and suddenly you have got the vaginal bleeding. So if you have a history that, okay, last 1 year, there was breast development and now bleeding happens, this looks more like a central precocious puberty. If you have no breast development and you have a bleeding, this looks like a local cause. But if you have some breast development and yet you have got bleeding, this discordant pattern suggests a peripheral precocious puberty, which is usually more likely to be pathological. Now, there are various causes which can cause the central precocious puberty, which will include effects like tumor, radiation, trauma, any insult will cause that. But most of it is 95% will be idiopathic. So beyond 6 years, we do not want to do unnecessary evaluation in the form of an MRI to identify a lesion. There are rare genetic causes which may also be there in that regards. Now, what our focus is most towards this aspect of the algorithm. So we'll talk about largely about McCune Albright syndrome as a possibility. Hypothyroidism, we all know the TSH, when the levels are very high, is going to act on the FSH receptor to cause this development. Rarely you can have an estrogenic adrenal tumor, which can cause that. So within the scheme of causes of precocious puberty, we'll be focusing about the peripheral precocious puberty, which will include ovarian, and we'll focus pretty much all these three as a group. And then you can have rare scenarios like aromatase, excess, or exogenous or Peutz-Jeghers syndrome as a form. So functional ovarian cyst is a very common finding, which is basically means that your dominant follicle has become bigger and it's producing estrogen, and it's usually LH independent. Now, the course is usually fluctuating and often it's a one-off phenomena. I'll talk about that as to if you have a single isolated cyst, whether you need to worry about genetic causes or not. That's an important issue. But mostly it's a single event. It will not happen repeatedly if it's just a functional cyst. And you will have a high estradiol levels, which will be there in that regard. So management largely is observation, and we'll talk about criteria when you need to worry about and when you can think of torsion or malignancy as a possibility. So a cyst which is less than 10 centimeters typically, who doesn't have a solid cystic area, does not require a surgical intervention. You can manage it conservatively. Granulosa cell tumor is exceedingly rare, but it is known to occur in children. So it's basically will have a very rapid production. Your estradiol levels will be sky high. So if you talk about a cyst, so what happened? There was a cyst, there's some bleeding, some breast development, and then regresses. Here it will be a continued process. It will continue to grow from that perspective. Your estradiol levels will be very, very high, and you will have other markers which will be produced. So if you have a granulosa cell, it's going to produce more of inhibin, AMH, all other factors will come from there. And you may also have tumor markers which are being produced. So this is more like a ovarian estrogenic tumor. Very rare, but if you have very rapid estrogenization, which is persisting, and you have a large cyst which has a solid cystic area, start worrying about this condition. Really, management, of course, is cumbersome. You will require gynecological referral, surgical intervention, and further management will come from there. Now, one important condition which we'll be discussing today is the McCune Albright syndrome, which is basically a problem in the GNAS1 region. So the GNAS is an important part as far as the cyclic AMP pathway. As far as the reproductive phenotype is concerned, this is because of overexpression or overfunction of the LH and FSH receptor, which basically will act on the ovaries to produce breast development, which will happen early, and you will have this discordant menarchal level. Again, the estrogen levels will become very, very high. Importantly, because you do not have much effect as far as the adrenal axis, you will not have pubarchy. They will present purely with a vaginal bleeding and some breast development. Because of very high FSH receptor expression, you will have large ovarian cyst. And the typical pattern is that, okay, you have got development now, you have got bleeding, you see an ovarian cyst, then the ovarian cyst regresses. There is a period in which there is no significant development, and then the second cyst appears. So it's like in the somatic areas where you have a problem in the ovaries. Now, this is a somatic defect. So not the entire ovary is affected. So it's not behaving like a testotoxicosis. Now, if you talk about testotoxicosis, that is a LHCG receptor activating mutation. So the entire testis is producing a huge amount of testosterone. This is not working like a ovotoxicosis. This is like certain cells in the ovaries, certain of these oocytes or the follicular cells will be starting to become more active. And so time and again, some of them will be selected and they will start producing. So it's a off and on waxing and waning phenomena, which is common in the setting of McCune Albright syndrome. Now, TSH, of course, there are many other hormones which act through the GNAS pathway. So in TSH, it will cause thyrotoxicosis. You will have growth hormone excess causing acromegaly in certain scenarios. You may have a ACTH independent Cushing syndrome scenario. Skin lesions, of course, which are very, very important, are again because of the melanocyte stimulating hormones. So MSH hyperactivity in certain regions will cause pigmentation, and you will have bone abnormalities in the form of hypophosphatemic rickets like scenario, or you may also have a scenario of fibrous dysplasia. So the classic description of McCune Albright syndrome, which is imprinted in most of our minds, is a combination of peripheral precocious puberty along with cafe au lait spots and fibrous dysplasia. Now, what you need to remember is that this is a textbook description, and in real life, the patient has not read the textbook. So they will not come to you with these three complaints that I have got McCune Albright because I have got an ovarian cyst, I have got a cafe au lait spot, and I've got fibrous dysplasia. They can come with multiple varying manifestations. They may just come to you with isolated fibrous dysplasia, which is a very, very common, most common presentation, I will say. So you will have bony lesions, some bony swelling, especially in the skull areas, in the hand. There may be a trivial fracture. So you have to keep your eyes and ears open that, okay, this could be a fibrous dysplasia. Think of McCune Albright in that regards. They may present to you just with recurrent ovarian cyst, where there is no other manifestations which are present that you have to be worried about. Similarly, in scenarios like macronodular adrenal ACTH independent macronodular disease, you have to think of a possibility of McCune Albright. Any child who has got growth hormone excess, McCune Albright is a strong possibility. Any child with hypophosphatemic rickets, think of McCune Albright. So you don't need to have the entire combination. Even a single manifestation becomes important. I'll talk a bit about criteria about McCune Albright a bit later subsequently. So this is a somatic defect, variable and fluctuating course, and you may also have a secondary central precocity. Now remember, it's a defect which is there in the GNAS pathway. So what's basically happening is that your pathway continues to be active because the GTPase action is compromised. So the whole process of cyclic AMP is continuously being produced in that regards. Now this defect may not be present in the whole blood because it's a somatic one. So often most of the tests are not able to detect this, and this becomes important from that regards. What about hypothyroidism? So uncontrolled hypothyroidism will cause a very high level of TSH, which will act on the FSH receptor to cause large ovarian cyst because there is a structural homology between the TSH, FSH, LH, HCG, and we have discussed this in many details. And this will cause large ovarian cysts. They may go up to 8 centimeters, 10 centimeters. I've seen cases who have been referred for surgical management, but then they are found to have hypothyroidism in that regards. They will have breast development. They will, of course, have vaginal bleeding, but they will have a delayed bone age because of the hypothyroidism primarily, and very importantly, because of hyperprolactinemia, they will have a low level of LH. So high apparent FSH activity, which is going to cause more ovarian stimulation, and low level of LH will basically mean that you have got no amount of pubarchy. So again, if you compare this scenario to a boy who presents to you with a severe uncontrolled hypothyroidism, they will again have the same scenario: large testis and no pubic hair. Similarly, large ovaries and no pubic hair. So effectively, von Wieck-Grumbach syndrome, as the term is called, is similar in manifestation in both boys and girls. It's just a matter of how they present. Depending upon menarche, you will get it much more easier in girls. In boys, as I said, FSH is a minor player. So high FSH will do nothing. It is not going to cause any change. It will only cause increased Sertoli cells, causing more testicular size from that regards. Again, no pubarchy is there. Rare scenario, which is similar to manifestations as far as McCune Albright is concerned, is Peutz-Jeghers syndrome. It's a problem. It's considered to be a neoplastic disorder, part of endocrine neoplasia syndrome. So it's the STK11. Again, this is going to cause more cellular growth. So all of these are causing more cellular growth. Manifestations are ovarian sex steroid tumors, which may again cause precocious puberty, which will be peripheral in the form. And very importantly, you will have pigmented lesions, which are there in the mouth, like lentigens. I'll showcase one of my papers, which I've done in Australia, which showed that MAS may also have these form of lentigens, and they may also cause gastric polyps. So there is an overlap between STK11 and GNAS1. So these are like all the growth pathways which are going to be stimulated. Subsequently, we'll discuss about that. Aromatase excess, extremely rare scenario. Again, it will cause precocious puberty. You will have high levels of estrogen and you will have increased growth and bone age in that regards. Now, when should you think of a peripheral precocious puberty? So basically, if you have a very simple traffic as it's going like this, it's a concordant pattern, it's more likely to be a central precocious puberty. But if you're traveling somewhere in Kanpur or something where you find such a bizarre sort of a traffic and everybody is going here and there, you think of it's more like a peripheral. It's like a organized chaos. That's what peripheral precocious puberty is. So it's a fast and discordant pattern of peripheral precocious puberty. Of course, the most important tests are gonadotrophins, and we all talk about the importance of LH, which is much more important compared to FSH. Invariably, if you think of central precocious puberty, your LH FSH will be 0. Anybody who has a high FT4 should have a 0 TSH. Anybody whose cortisol is high should have a ACTH, which is undetectable. Similarly, if you have very high estrogen, you expect your basal LH to be less than 0.1. So generally, you are not in much doubt, but you can do a GnRH stimulation test if there is a confusion. You give a triptorelin or you give leuprolide 20 microgram per kg, 100 micrograms, and then you check your LH levels after 0, 2, and 4 hours, and you will find that there is lack of response, which will suggest that this is a peripheral precocious puberty. For me, a very high estrogen level and an undetectable LH is pretty good enough. You then have to go for imaging in that regard. So what you do is that if you have complete development and your LH is prepubertal, you have to go for peripheral precocity and go for imaging.
This was a girl. The history of presenting illness was, as per mother, she was asymptomatic till 1 year of age. Then she started having episodes of bleeding per vaginum, which were recurrent, and had abnormal breast enlargement, left side more than right, for which she was evaluated by endocrinologist at 2.5 years of age. She presented to us a month later and was evaluated for the same. So there was no history of any foreign body insertion or trauma to genitals. There was no history of any headache or seizures. There was no history of any medication, drug use, or any bony abnormalities or skin lesions. Birth history, she was a full-term normal vaginal delivery. Birth weight was 2 kg and non-consanguineous marriage, and she had a normal milestones. On examination, anthropometry, her height was 94 centimeter at the age of 2 years, which was plus 1.99 SD. Weight was 13.5 kg, which was plus 0.63 SD. SMR was breast stage 3, pubic hair stage 1. And on examination, vaginal mucosa was pale. And there was no clitoral enlargement.
So, Dr. Priyanka, before we go ahead with the investigation, now if we compare this case with what Dhwani had presented, our case, this case is a much earlier presentation. So starting at 1 year of age, I think that's a major difference. Second major difference is the height advancement. So I think that's the other major difference which is there. And probably these two will suggest that this is even sooner and likelihood of a pathology will become much more in that regard. So, but the pattern that you are seeing, as you were suggesting that again, there is a breast development is marginal. It's mainly the menarche and the bleeding which is there. So this looks more likely to be a peripheral precocious puberty as well. So let's go on the investigations, please then.
First of all, bone age, X-ray bone age was done. So it was advanced. At the age of 2.5 years, the bone age was 4 years. Then further workup was done. The routine investigations were CBC, PT-INR, serum electrolytes were normal. FT4, TSH were in the normal range. Cortisol, prolactin were normal, but estradiol was high at 82. FSH and LH was suppressed less than 0.1, and testosterone was less than 20.
So what we are seeing clearly again is this is like a peripheral precocious puberty, but compared to the case we discussed just now, the estrogen level is lower, is much higher. There the estrogen level had come down, so it means there is a persistent estrogen excess. The LH, of course, is undetectable. So this again goes in favor of that. And FSH is marginal. So that is a normal sort of a response. Yeah, please go ahead.
The GnRH stimulation test was done. The basal level of LH was less than 0.03 and which did not rise after 1 and 2 hours, remained at 1.8 and 1.8. And FSH was 1.23 basal and which rose to 14.18 and 13.7 at 1 and 2 hours. MRI brain was done to rule out hypothalamic hematoma, and whole body bone scan was done, which was suggestive of, showed no evidence of fibrous dysplasia. So USG showed left ovarian cyst around 3.3/1, and endometrial thickness was increased 4 to 4 millimeters. So it was a case of peripheral precocious puberty, and most likely the cause is McCune Albright syndrome, considering the recurrent episodes of vaginal bleeding associated with recurrent ovarian cysts.
So now, if you look at this case compared to other case, this is the earlier onset, more severe recurrent features, even though you don't have any fibrous dysplasia, even on a bone scan, even if you do not have any skin lesions, we are still much more cautious about the possibility of McCune Albright syndrome, which is there in this scenario. Yeah.
Initially, at 2.5 years of age, when the child was first evaluated by the other endocrinologist, aromatase inhibitor letrozole was started at 2.5 mg OD, but she still had episodes of recurrent vaginal bleeding with that treatment. So when she presented to us, she was started on tamoxifen, which is selective estrogen receptor modulator at 10 mg OD doses. On this treatment, her bone age advancement was slowed down and episodes of bleeding were decreased. But she still on follow-up has sometimes episodes of bleeding on and off, for which we have to give progesterones, course of progesterones. And she's on follow-up, she is regularly followed for bone age and endometrial thickness.
And how is her growth pattern? She is, I think, in the normal range for height at the moment.
Sir, she is presently 10 years old and she came last at 9 years of age, and her bone age was around 10-11 years.
Okay, so and she hadn't entered into central precocity as well. So
no,
I think this is very, very good that we have been able to control her puberty, because at that level of estrogen of 80, if you have continuous or recurrent exposure of that, your bone age has to go up very rapidly. And often by this time, or maybe at much younger age, you will have a secondary trigger. And then it becomes very difficult to manage from there. Yeah. So carry on, please.
So about McCune Albright syndrome, it is a somatic activating mutation of alpha subunit of G protein coupled receptor GNAS1. It presents with recurrent ovarian cyst and peripheral precocious puberty. It is associated with excess of other GNAS hormones presenting with thyrotoxicosis, GH excess, Cushing syndrome, hypophosphatemic rickets, fibrous dysplasia, and multiple cafe alert spots with irregular margins, differentiating it from neurofibromatosis. Management is involves the inhibition of estrogen production or action. So aromatase inhibitors like anastrozole or letrozole have been used, but the other drugs are selective estrogen receptor modulators like tamoxifen, which is superior to aromatase inhibitors, and the drug of choice are estrogen receptor antagonists like fulvestrant, but it is very costly, so that is why it is less used.
So I think thanks a lot. This was a very, very interesting case to look at, because this really provided us with a lot of insights about when should we suspect McCune Albright and a scenario. So one thing which is always there in our minds is that we think about a possibility that, okay, McCune Albright syndrome, basically, you have to have all the three things. You need to have a cafe au lait spot, you need to have a fibrous dysplasia, you need to have a ovarian cyst. So this is not essential. So effectively, this is a most likely scenario of McCune Albright. Now, how do we diagnose? How do we confirm? And this is what I will be talking a bit about. Usual scenarios which can often happen with McCune Albright as well. This is one of our publications which I published from RCH Melbourne. And this is a very interesting scenario in which we are seeing overlap between Peutz-Jeghers syndrome and McCune Albright. So these are these four boys, and there were a couple of boys and a couple of girls. All of them had got very peculiar lentiginous-like pictures. So they were behaving like Peutz-Jeghers. They were found to have a gastric polyp. And this basically suggests that MAS, the involvement may be very wide. And we need to be cautious about development of other tumors as well. We also identified that there are platelet dysfunctions which may happen in the setting of McCune Albright, which we need to be cautious. So the classical phenotype of TSH, GHRH, or ACTH or MSH is much wider as far as McCune Albright is concerned. You can have, of course, cafe au lait spots, large ovarian cyst, thyromegaly, thyrotoxicosis, along with thyroid nodules which may develop. You may have a growth hormone excess which may happen, and you can have multiple areas of involvement like skeletal dysplasia and fibrous dysplasia which may happen. So how do you diagnose? And this is the group which has done the maximum work as far as McCune Albright is concerned, the NIH group. Now what they are saying is that you need to have 2 or more clinical features to reach the diagnosis. And the classical features are, of course, fibrous dysplasia is the most common, cafe au lait spots with characteristic features, gonadotropin independent precocious puberty, then testicular, thyroid, and other scenarios. So this is something which we need to be very, very careful about in that perspective. So they're talking about 2 or more as a criteria. But that does not mean that if you have a girl with recurrent ovarian cyst who is behaving like, can still have a GNAS activating mutation. Whether you call it McCune Albright or not, doesn't matter. Now, this is what I was discussing about the cafe au lait spots. So Dhwani was describing about those small cafe au lait spots. So what they mention is hyperpigmentation with irregular border, distribution reflecting the midline of the body. So it's not the size, it's the pattern which becomes more important from that perspective, which was seen in this case. And now about diagnosis, the major problem is that this is a somatic mutation. So you may not be able to identify the scenario. So what they're saying is that if you take the blood, only 20 to 30% may be having a positive diagnosis on the blood. You may have a higher chance, approximately 80% if you take the lesion. So if you look at the ovarian cyst, the tissue, if you take the skin biopsy from the cafe au lait spot, if you take the fibrous dysplasia, you will get a much higher yield, but still your genetic diagnosis is not going to be 100%. So it cannot exclude. So what they have said is that if you have a positive result, it confirms McCune Albright syndrome, but a negative result does not exclude the condition. And therefore, routine role of genetics is not going to be very significant. Your management is not going to change. If you have fibrous dysplasia, you manage it like that. If you have a peripheral precocious puberty, you manage it as a peripheral precocious puberty. If you have thyrotoxicosis, you manage like that. So it's not that if you don't find on genetics, you don't need to really think that, okay, we can't do anything. This is not McCune Albright, importantly. Now, this is a very important question. If you have a prepubertal girl coming to you with ovarian cyst and you've excluded hypothyroidism, there are no other features, this looks like isolated, can it have a genetic etiology? Now, this was an interesting study which was done from the French group. Dr. Sultan was the main lead in that, and he had actually done studies about the prenatal ovarian cyst as well. And this was quite a long time ago in this scenario. So what they did was that they tried to evaluate for a number of genes which can potentially cause ovarian cyst. And they studied in these 11 patients. And what they found was that they did not find any of these mutations. The important ones are GNAS1, LHCG receptor, of course, and FSH receptor, star. So all these defects they could not find. So what they're saying is that most of these isolated ovarian cysts are non-genetic in nature. So you don't need to worry too much, especially if you have a single lesion. So don't go ahead and worry about that. Of course, look clinically for a cafe au lait, look for the skeletal abnormalities, but you don't need to be too much bothered about reaching a genetic diagnosis in that regard. Now, how do you manage Dr. Priyanka has already mentioned. So specific management would be at the level of either blocking estrogen production, like using aromatase inhibitors like letrozole, blocking the estrogen action using a selective estrogen receptor modulator like tamoxifen or fulvestrant, which is an antagonist. Then if you have thyrotoxicosis, you use methimazole / radioactive iodine. GHRH, of course, it's a long-acting, it's a hyperplasia. So you can't do a surgery. So you have to think of a LAR or a pegvisomant group of drug, which will be there. For ACTH, you have to use metarepone or you can use ketoconazole. Rarely, you might have to need a adrenalectomy, which is there. And for fibrous dysplasia, pain, lesion size, and other parameters, zoledronic acid is the clear-cut treatment of choice from that regards. Rarely, if there is a secondary central precocity, you can use GnRH analog in that setting. As far as puberty is concerned, as discussed, aromatase inhibitor letrozole has been used, but it tends to increase the ovarian size and it is less efficacious. So we don't prefer letrozole as a primary therapy, and that is why in the case we shifted from letrozole to tamoxifen. We prefer tamoxifen, but there is a chance of developing ovarian cysts may become bigger. So you have to monitor that size in that perspective. And of course, the estrogen receptor antagonist fulvestrant has been shown. I'll show a study also to have a much more potent effect, but you need to give injection. It's a more expensive treatment, and that's why you need to be a bit careful about from that regards. So this study clearly shows that if you use letrozole, you will have improvement as far as the bone age is concerned, as far as the estrogen levels are concerned, but the ovarian volume may actually increase significantly. So the use of letrozole is not favored as a primary agent in McCune Albright syndrome. Tamoxifen has been shown even to the final adult height that it results in a significant increment of height, and what they are saying, in fact, from 145 to 157. So it's as good as using a GnRH analog. So tamoxifen, and I find this case, we had a very good response. She had an onset of 1 year. So now at 10 years, if we are able to allow the delay in bone age progression, and if we are able to avoid central trigger, it's going to be working very well in that regard. But you have to tell them that this is need to be done on a daily basis. You can't just keep on giving and stopping, and then again things will happen. And there will be times when you have some cysts which are formed. You may have high estrogen at that time. You may treat at that time, but continue tamoxifen in that regards. Now, fulvestrant, and this is again a study from Dr. Sultan's group and Erika Eugester's group. And what they have shown clearly is that this is a good drug. The frequency of vaginal bleeding becomes much less. There is improvement in terms of bone age and other parameters as well. So this is a selective estrogen receptor 1, ES1 antagonist, or estrogen receptor alpha antagonist. Dr. Elizabeth is asking about estrogen levels in functional ovarian are high enough to cause breast development and bleeding, but do not accelerate the bone age. Dr. Elizabeth, this is related to the fact that the duration is also important. So it's not just how much your levels are, how long these levels are. So usually these cysts will regress in certain times. So it does not cause acceleration bone age, but if it's persistent like McCune Albright, you will have a scenario in which it will increase. Dr. Bharani is asking what proportion of increase in bone age in exogenous estrogen versus McCune Albright, because I've seen girls with estrogen with raised bone age. Yes, so if you give exogenous estrogen at a very high level, of course you will have a scenario in which you will have a very rapid development which will happen from that perspective, and then bone age can really accelerate. So Priyanka, who is currently working as a pediatrician at Monilek Hospital in Jaipur, and she has been very enthusiastic participant in our MedEClasses sessions, and she'll be presenting a case which we managed jointly, a very interesting young girl.